thanks very much for the invitation to speak, first of all. It's great to be able to come and talk to so many different people from so many different backgrounds. I think before I start, one of the things that that's always difficult is that I can't see anybody, so I can't see people's reactions or anything like that. So it's very difficult to gauge kind of the level that we're pitching things at. So hopefully I've got things at an appropriate level, but I'm happy to discuss things afterwards. So if you want stuff in more detail, or if you want stuff stripped back to basics a bit more than happy to do that in the Q&A session. The other thing to say is that I apologise, but I'm still the strategic medical advisor for Yorkshire Ambulance Service tonight. I've not been able to swap out of it. I've asked them not to call me for this hour unless the world is ending. So fingers crossed we'll be all right. So moving forward, primarily I'm a consultant in emergency medicine, but I'm seconded to Yorkshire Ambulance Service for 50% of my time, where I'm the medical governance lead and one of the strategic medical advisors. I'm the lead consultant for the Yorkshire Critical Care Team, which is the doctor paramedic team on the Yorkshire Air Ambulance, and I'm the lead consultant for the West Yorkshire Medic Response Team, the governance lead for the YAS BASICS Immediate Care Team, and so on. I'm the vice chairman for the British Association for Immediate Care, and I'm the chair of the Yorkshire group of the Faculty of Pre-Hospital Care, and I'm one of the examiners for the fellowship up at the college. So that's a bit about me, but I should stress that some of the opinions I'm going to express tonight are not necessarily the opinions of those affiliated organisations. They're just my opinions. So there we go. Apparently there's a football match on tonight. So thank you for choosing to dial in here instead. The BBC did ring and express concerns that we're going to take away a lot of their viewers tonight, but we'll see how we get on. So things to consider tonight. I wanted to just talk about medical priorities at a road traffic collision where there's a patient trapped and how we should go about it. Because this is going to be something that's very common. We'll go to a lot of RTCs, and a lot of them people are trapped. And we probably muddle through them and we think we're doing a good job. But actually, if we stop and break things down, we possibly could do things better. So I think it's worth just reflecting on that, and that's what we'll look at tonight. Before we get onto that, how big a problem is major trauma? Back in 2016, NICE defined trauma. They told us that it's got a bimodal age distribution, with the first peak in the under 20s, and that it's the biggest killer of people aged below 45. And what that means is that is a big medical disease, whatever you want to call it, big medical problem for our young population. So clearly, at a personal level, any major trauma is always a tragedy, but at a slightly more callous, bigger level, having all of these young people taken out of work, having to pay a lot for kind of their rehab and then potential ongoing care, is a huge economic burden on the country as well. And they estimated that the cost of treating major trauma in the immediate phase is between 0.3 and 0.4 billion pounds per year. They couldn't get figures for all the ongoing rehab and home care support, etc. But on top of that, the National Audit Office said that we lose between about 3.3 and 3.7 billion per year. So add those figures up, and major trauma is a huge health problem for this country. So anything that we can do that improves outcome and reduces mortality is a good thing. And that's why I think it's important to focus on some of this detail tonight. In terms of how common it is, back in 2010, so slightly outdated now, and these numbers have probably gone up, but there are about 20,000 cases of major trauma per year in England, which is huge when you think about how many that is per day. And of that, nearly 5,500 people will die, with a lot of others sustained permanent disability, not able to return to work, and obviously impacts on their private lives, which is that's a huge amount. So in other words, it is really common and it is a big problem for us. If we think specifically about RTCs and RTCs where people are trapped, Tim Nutbeam and the team did a really good piece of work, which was published earlier this year, looking at the demographics of RTC entrapments. They looked at the TARN database, so patients admitted to English hospitals between 2012 and 2018, and they identified nearly 64,000 patients, and about 11% of those are trapped. So that's about our entrapment rate, so 1 in 10, just over. When they've looked at some of the detail around that, they found that patients that are trapped have a higher injury severity score than those that weren't. And they also found that patients that were trapped had a higher mortality than those that weren't, again, with very statistical significant figures. and that goes along with the injury severity score. So entrapment is significant. They went on to look at it a little bit further, and they found that overall spinal cord injuries were very rare, accounting for just over 0.7% of all extrications. But what they did notice was that 1 in 2 of those was associated with other severe injuries. Spinal cord injuries were more common in patients who were trapped than those that weren't. And we'll come back to that frequency of spinal cord injuries, but it's worth just remembering that actually it's pretty rare. Trauma patients had more deranged physiology with lower blood pressure, lower SATs, lower GCS, and so on. And they had more significant injuries throughout all of the body, but significantly an increased rate of pelvic injuries with blood loss, and we'll come back to that later on. Okay, so people who are trapped, they're more severely injured and more of them die. If we think about types of entrapment, there's people define them in different ways, but basically there can be absolute entrapment, which is where the pedals are wrapped around your lower legs and you're properly pinned. Or it can be that just the door's a bit bent, so you can't open the door, so you can't climb out. Or it could be that perhaps you've got a fractured femur and that the pain and the injury are stopping you getting out of the vehicle. But all of those things, they will all need us to do something to create some space to relieve pain, to actually extricate the patient from that. So if we just step back again, then RTC, it's common and patients are frequently seriously injured. For us to be able to manage that group properly, we have to get them out of that vehicle. And that needs a multidisciplinary team to come together to do that. Now that will be fire and rescue. It might be technical rescue. It might be an ambulance crew. It might be a responder. It might be a clinical supervisor or a bronze commander. It might be a HEMS team or a basics doctor, and so on and so on. A lot of people have got to come together to work for the benefit of this patient. And those people probably will never have worked together in that particular configuration before. And that makes it difficult because actually collaboration and working together is a really important part of this process and getting it right. Talking in a common language will help the process. So in a second, I'm going to talk about the stages of extrication, just to give us a better understanding of that. But it's also worth thinking that we should all be thinking around JESIP principles, so Joint Emergency Services Interoperability Programme. And I'm not going to go through that in detail, but these are the 5 principles that we should be working with. So co-location. So the commanders at an incident should get together as soon as possible. The picture on the right, incidents won't always be as big as that, obviously, but actually the fire commander and perhaps the ambulance lead should be getting together. They need to be communicating and just talking to each other face to face. Just cut the jargon, just talk plain English. And then they need to coordinate and identify what are the priorities. How are we going to get this patient out? Do we need to treat the injuries beforehand? Does this plan fit with the injury pattern? And so on and so on. And by understanding all those principles, understanding the risk and keeping each other updated, we'll work together better. So we need to try to bear in mind these JESIP principles and utilize them. So I'm really sorry. This was inevitable. Hang on. I'm so sorry. You go days without a call, and it's just typical, isn't it? Okay, so how should we manage an RTC? We turn up, there's a patient trapped. What should be our approach to manage that? So I've just pulled together a bit of a brainstorm thing. It's just some stuff I throw down. We arrive and we're told it's an entrapment, or on the way we're told it's an entrapment. So we can start to get our thought processes together for that. We need to have an assessment of the scene and the incident to make a plan early doors. Now, fire will almost certainly have arrived before we have. At least where I work, that's what always happens. So it is invaluable to go and talk to the senior fire officer and find out what intelligence they've gathered, what their plan is, and then we come together and we make a plan for the release. A few things then need to happen in unison. Fire service will lead on the technical extrication, so the taking apart of the car and getting the patient out, but they will work with the medical team doing that. They're not going to work in isolation. At the same time as that, the medical team may well need to get into the vehicle to provide medical care for that patient, whether you need to open the airway, give oxygen, TXA, whatever it might be. At the same time as that, we're not going to stand around twiddling our thumbs. We're going to be very proactive and actually quite aggressive about our kind of off the ball, excuse the pun, management. We're going to set up a resus kit dump if that's potentially needed. We're going to update the ambulance control room and the local emergency department, or the one that we go into, of what's happening. We're going to start thinking about which hospital are we going to, major trauma centre, trauma unit, which one's nearest, how are we going to best get there? Are we best to fly? Are we best to go by road? And taking into account there things like all of the FAF factors for loading onto a helicopter. If we're going by road, we need to be thinking about which way are we going. Is the one way we want to go actually blocked by the incident? In which case, is there a more appropriate hospital to get to quicker? Is the ambulance pointing the right way? Is the road blocked by fire engines, etc., etc.? So there's a lot of work which we can be doing, even if we're not physically with the patient. And those things are all going on in parallel, which will hopefully minimize our on-scene time. We then come together and we give any further medical treatment that's needed once that patient is out. We finish packaging the patients, finish immobilizing them, and we take to the appropriate ED. And by doing all of that, hopefully we can reduce mortality and reduce morbidity. So I'm going to break down some bits of that and we can dig into it a little bit more. There are lots and lots of different extrication techniques, and I don't claim to be an expert in this, but fire service will work with us and they'll explain the options to us. And you can talk about taking the roof off, taking doors off, dashboard rolls, all sorts of things. But they'll talk to us and can work with us. There are 6 standard phases which are traditionally described, but we have to be really mindful that those are just a starting point, and we have to adapt them as necessary depending on what that situation is in front of us. So the 6 stages, they're a good foundation to build off, but they're not going to be what we do every single time. Before we get onto those 6 stages, it's worth just thinking about the time frame of the extrication that we want. If you turn up to a job and perhaps the patient's in cardiac arrest or they're peri-arrest, or there's a developing danger to that patient, you might just need them out of that vehicle right now. And that will just be that they're lifted or pulled from that vehicle. There's not a lot of finesse to it. We put as much control in as we can, but actually it's just a matter of get them out right now. At the other end of the spectrum, people talk about their plan A, or a controlled release. And that is usually about creating as much space as we can in and around the vehicle, maximizing the safety for that patient, allowing us to give treatment in situ before we lift them out. And that's great, but the flip side of that is that often takes a lot longer to do that. And so patients can deteriorate, and we'll come back to that. In the middle, there's a rapid access. That's your plan B. So what happens if we're doing plan A and the patient deteriorates, for example? And that is where there's a kind of in-between plan to get them out. So we get them out quicker, which is great, but it's less controlled. So there's more risk of movement. So there's more risk of spinal injury. There's more risk of deterioration from bleeding, from pelvic fractures, intra-abdominal fractures, and so on. So it's a balance. But early on in the process, we should be having a conversation with fire to determine what is our plan A, what is our plan B, all of that kind of thing. So these are the 6 stages: safety and scene assessment, stability and initial access, glass management and space creation, although they're often interchanged, full access, and then immobilization and extrication. As I mentioned earlier on, a lot of the time fire will be at incidents before the medical teams are. So actually you find that often the first 2 or 3 or even 4 steps are well underway before we get there. But if we break them down, I think it's helpful to have an understanding of the structure that the fire service might be working from. So the first stage is when they arrive on scene, their incident commander takes overall responsibility. There will be a survey of the scene, both an outer survey where they'll be looking at hazards, looking at mechanisms of injury, looking at how many vehicles there are there any ejected patients which have been missed? And they'll be trying to do what they can to minimize hazards. So looking for chemicals, is there a risk of fire? Is there risk of other vehicles coming in if the road's not closed? And they will do what they can to mitigate those risks. But it's really important to to remind ourselves that actually no scene is guaranteed as being safe, and safety is an individual responsibility for us, and we have to take that on the chin and be mindful of that. As part of that, stage 1 will be the first patient contact. So they're not really doing anything to assess injuries, but at that point, they're just trying to determine where are the patients, how many are there, what's happened to them, how are they trapped, what's been the mechanism of injury, and then they can start to determine what are those injuries likely to be. The other part of stage 1 is that a kit dump will be set up for the fire service equipment and a debris dump area for when they start dismantling the car, where they can put the doors and the roof and things that have come off. Now that sounds like quite a lot of stuff to be happening in that first stage, but actually it happened in parallel because there's obviously more than one firefighter that can be doing different things. So that will happen very, very quickly, and that gives the fire service a good overall picture of what's going on. Stage 2 is where they get stability of the vehicle. Now, if a patient needs time critical interventions, they just need dragging out or something like that, they can just do manual stabilization, just using the firefighters to stabilize the vehicle. But that would be unusual. And in most instances, they will use chocks and blocks to stabilize the vehicle, particularly when it's on all fours. And that can be done very, very quickly. So that will be in most cases. If you've got a slightly more complex entrapment, so a vehicle on its side, for example, or resting up against something else, then they might need to use slightly more fancy toys to stabilize the vehicle. And that's their area of expertise. But yeah, so often you see ratchets and props and things being dragged out. The one thing that we need to be mindful of is that if we get into a vehicle, we destabilize it. So we need to be really clear that fire are happy for us to be getting in and out of vehicles before we start doing that, because we can cause a problem. The other part of stage 2 is that as soon as they've got that stability, a firefighter will get in and make an assessment of the patient to make any immediate life-saving interventions that need to be done. So that's pretty quick after they've arrived. Stage 3, as I said, stage 3 and stage 4 are sometimes swapped around, but stage 3 is glass management. So obviously cars have got a lot of glass on them, and we need access through that glass to get to the patient. And the glass management system is a way of managing that glass safely to minimize the risk to the rescuers and to the patient. And it's not just big fragments of glass that are danger, that you get glass dust, so inhalation can be a problem. And different cars of different ages have different types of windscreen made from different materials. And so the fire service may need to be mindful of that so they know what technique they're going to use. Sometimes older windscreens, the seal around the edge can just be unpeeled and the glass lifted out. Sometimes you need to cut through the glass. Sometimes, if possible, you can wind the window down. But whatever we're doing, we're going to use protective sheets and teardrops, which is a big plastic board, for want of a better word, particularly to protect the patients when we're managing the glass. And we're also going to create some space. Now, that is just to allow us to get in to give any treatment that we need to for that patient whilst we're doing the formal dismantling of the car to get the patient out. So there's different ways that we can do that. Sometimes you can do very simple things like open a door. Sometimes you can recline a seat, or you can slide a seat back. Sometimes the steering columns can be adjusted to lift forward. All those kind of things are very simple things that can be done to create a lot of space, which is great. We need to be mindful of what we're doing. So in the bottom picture, which is very well advanced actually, but the seat is well reclined. So that would be great, but you might need to be mindful if a patient has got ventilatory compromise, for example, or significant facial injuries where they're bleeding, they might be relying on postural drainage, and if you lie them flat, you might make it worse. So as I said, you need to be dynamic with these plans and look at the patient and look at the options that you've got. Roof removal is usually considered standard when you're creating space, but it is fairly timely to be doing that. So we have to be really clear, do we really need to do it? And we'll come on to that. Stage 5 is where you really get yourself good access to get into that patient, to give the treatment you need, and then to allow you to do a controlled lift or extrication from that vehicle. But as you can imagine, that might take a bit of time to get us to this point. Stage 6 is actually extricating the patient from the vehicle, making sure that we're using appropriate immobilization at the time. And there are different techniques that we can do that, but the traditional one is, as you see in that picture, a long board being slid in behind the patient, and then the patient is just lifted and slid up that board. The board is then brought flat and the patient's lifted out. That's fine, but to lift somebody up that, particularly if they're big, is actually really quite difficult to do. And there's a significant risk to the rescuers of musculoskeletal or back injuries, but also there's a risk to that patient, because if somebody were to slip, or even if they don't, the movement that we put them through there is a risk of movement of the neck or the back. There's a risk of further moving fractures, of causing further bleeding, intra-pelvis, intra-abdominal, etc. So we need to be really mindful of, is this actually the best thing for this patient? And sometimes it will be. I'm not saying we never do it, but sometimes it isn't the best option. But anyway, they're the 6 traditional stages of extrication which we would consider. In terms of extrication devices, we've talked about longboards so far, and these are the kind of traditional extrication device. They're flat, they're often fairly slippy, so patients can slide up them, and that's great. And if we were to go back, I say a few years, it's quite a few years now, I'm getting old, but if you were to go back a few years, patients were conveyed on longboards. We've really started to go away from that now. Patients should only really be conveyed on scoops, and we'll talk about that, scoops or vacuum mattresses, and we'll talk about that in a little while. So, immobilization. There's a huge amount of dilemmas and discussion and disagreements about this in the pre-hospital community at the moment. Some of the things that are fairly well established. So if a patient can self-extricate, they should be invited to do so. And there's good evidence that actually they will protect a spinal injury self-extricating themselves better than we would do trying to lift them out. Obviously, if the patient's unconscious or seriously injured, they're not going to be able to do that. But also the flip side of that is the people that are unconscious or more seriously injured are the ones likely to have other significant injuries that are going to need that time critical intervention. So there's that paradox where we need to balance caring for a potential spinal injury with the need to manage actual injuries that we can see right there in front of us. And there's that bit of a balance. And the other thing to think about is that we're being really careful of this spinal injury, but actually if we're taking longer to get somebody out of the vehicle, are we exposing them to a longer period of hypoxia and hypotension, which of course is bad for the cord injury anyway. So actually we need to just think about this. And this is where we need to be flexible and dynamic with our plans. So we're not going to have one rigid system which is going to apply to every incident. We're going to go in and assess it on its merits. So I kind of hesitate to go into this area, but the current gold standard practice is triple immobilization, so collar blocks and straps or tape. As part of that is collars. So currently there's a huge amount of controversy up and down the country. There will be some people who say all collars should be put in the bin and we should never use them. And there'll be some people who say, no, collars are really good and we should use them with every single potential neck injury. And then there's a lot of people somewhere in the middle. So part of the concern about collars is that they can make managing the airway more difficult. If you've got a collar on and a patient vomits, for example, it's harder to get in there to suction that. It's harder to do a jaw thrust or a chin lift. And so it increases the aspiration risk. And if a patient aspirates, then in terms of hypoxia and pneumonitis later down the line and so on, that's all very bad. Wearing a collar is very uncomfortable. So actually it can increase agitation for a patient and make them much harder to manage. And we'll talk about agitation towards the end. A tightly fitting collar can also increase intracranial pressure because it reduces your venous return. So all of those things are actually fairly negatives from a collar. Combine that with the fact that there's now a doubt about how effective they actually are in terms of moving the head, means that people are starting to think that we shouldn't be using them so much. On the flip side of that, there's such a well-established part of pre-hospital care that people are very scared that if they haven't used a collar and they've missed an injury, then they'll get in trouble at work or they'll end up getting sued or something like that. And we need to be clear that actually by not using a collar, we're not saying we've cleared the neck, we're just not applying a collar. And there's a big difference between the two. But just have a quick look at just a few of the papers I just pulled out from this. The first one was looking at the evidence for the use of spinal collars in stabilizing spinal injuries. They did a systematic review of over 30 years, looking at the evidence. They wanted to try and resolve the discrepancy between current practice and the evidence out there. And they found what they thought were 9 eligible studies, and 6 of them said that collars shouldn't be used in pre-hospital trauma patients. 3 of them said there was uncertainty about whether collars were best practice. So the authors noted a discrepancy between current guidance and practice, but they noted that none of the studies actually said there was a benefit from the collars. So they recommended that further direct research was needed. There was a paper back in 2019 where they came up with 3 recommendations. They said there was a strong recommendation against spinal stabilization of patients with isolated penetrating trauma. Fair enough. A weak recommendation against the pre-hospital use of a rigid cervical collar and hard backboard for ABCDE stable patients. That's okay, but there's a lot of stuff in there. So backboard and collar, kind of 2 different issues. And what about the non-stable patient? And how do you define stable anyway? So a little bit of an issue there, and a weak recommendation for the use of the vacuum mattress, which is fair enough. Rachel Hodgett and Richard Ward published in the Journal of Paramedic Practice in 2020, and they said that the evidence suggests that cervical collars cause more harm than good, and that the ambulance services should reconsider. And the last one I'm just going to mention was just from Tim Monteith, who he kind of reflected that we've been using collars for a long time, but there's no real evidence of the benefits from it. And he said that there's a growing body of literature challenging the current dogma and prompting reevaluation. And I think we would all agree with that, yeah, it would need a bit more definitive answer. So thankfully, there is an upcoming study going to be taking place looking at cervical spine immobilization following blunt trauma. So hopefully this will give us some answers when it comes through. So my practice at present, so if a well-fitted, and that's a key word, if a well-fitted collar can be applied and it's tolerated, I think it's useful, particularly during the movement or the extrication phase, especially if the patient's got a reduced conscious level, because you can imagine the head will just be flopping to the side if there's nothing to support it. And I'm not saying we let go of the head, but that collar is just an extra little piece of support. However, if you can't fit a collar, so on me, I know that you will not get a collar to fit me. So it's better to have no collar than a badly fitting collar. Or if it's not tolerated, so the patients are getting more agitated, then we can just leave it off. Okay. If I've put somebody to sleep, I will then, once I'm repackaging them, I will often leave the collar off or just leave it open. Because in significant head injury, one of the things that we want to do is avoid any increase in the intracranial pressure, and so we don't want to impede that venous return. So yeah, so particularly in anaesthetized patients, and they're paralyzed anyway, so they're not going to be moving. So that's my practice at present. But like I say, omitting a collar doesn't equate to clearing the C-spine. So just to move on then a little bit now. So we spoke earlier on about medical interventions, either in situ or once the patient's out. So what kind of things should we think about doing? And the key thing is that we should do as much as necessary, but as little as possible. In situ, and this is not a definitive list, these are just things that we might have to do. We might need to manage an airway. That might just be simple maneuvers, it might be suction, it might be an adjunct. We may well want to apply some oxygen. We might need to decompress a chest, for example. We might need to put up some fluids or some blood or blood products. TXA early is interesting. If you were to go back a few years, TXA was often a bit of an afterthought in the ambulance on the way to hospital. But the evidence these days is that the earlier TXA is in, the better. So really, that should be going in early doors. So yeah, often while the patient's still in the vehicle. We may well need to give some analgesia. Not ideal, but we may need to give some sedation. And things that are often considered, IV paracetamol. Don't underestimate how good that is, particularly if you're using it as an adjunct alongside another agent. And then morphine, fentanyl, ketamine, Entonox, Penthrox, midazolam, and lots more. There are lots of different agents there, which will depend on the user's familiarity with the agents, but also what the situation is. But we need to be aware that any drug that we give has got potential complications, and we need to be in a position to manage them if we're going to give those drugs. Now, that might be hemodynamic collapse. It might be knocking off the respiratory drive, might be knocking the conscious level. So we need to be in a position to manage those things before we just whack in the drugs and cause harm. So we need to be mindful of that. Once they're extricated, we can do all of the above if necessary, if it hasn't happened. We can do a bit more as well. We can give a pre-hospital emergency anaesthetic if required. We can manage fractures, I think, particularly around pelvic binders if needed, and Kendrick traction devices if needed, and surgical procedures, particularly chest procedures if they're necessary. All of these things should be planned and prepared for during that extrication phase. So we mentioned this earlier on. We shouldn't be getting somebody out and then thinking, oh, we need to set up an RSI kit dump or something. That should happen before. So the patient comes out, they're moved into our resus area, bang, we do the procedures, and then we're off to hospital. We're just minimizing that time. In terms of packaging, I mentioned earlier on, a lot of patients are extricated on longboards, but we then need to move them onto a scoop. Part of the problem with the longboard is because they're very flat, they have, I think it's 7 points of contact with the body. And that means you get pressure areas developing pretty quickly. So that can lead to skin breakdown, but it can also just be really uncomfortable. So the patient can become more agitated and more difficult to manage. The other thing to think about is if you've got somebody on a longboard, when you get to the ED, they need to roll to 90 degrees to get them off the longboard. And if you've got pelvic trauma or abdominal or thoracic problems, that's problematic. And then there's another 90 degrees to roll them back. Whereas if they're on the scoop, you just unclip and job done. So actually it's really beneficial to be on a scoop. If you've got a longer transfer time, if you carry a vacuum mattress, then that's really a good idea. And we should be utilising that. The other part of packaging is make sure that your lines and your tubes are all secure and not going to get pulled out, because it always happens. Untangle everything as best you can, and do what we can to mitigate hypothermia, particularly if you've stripped the patient down, which we should have done. So we're thinking about whatever devices you want to use, whether it be a Gerotherm or a Flectalon or whatever, utilise what's in your service to keep them warm and keep the ambulance as warm as possible. So I'm going to take a sip of tea because I've got a sore throat. Which patients do we actually need to get out quickly? This is one of those key questions that we need to think about early on and work with fire to determine. Some are really obvious. Patients are arrested. Some patients are peri-arrest. Some patients are unconscious. They're easy. Yep, get them out. But I would argue, what about those with occult injuries who will deteriorate if we leave them in situ? Because that group, the traumatic arrest, peri-arrest, unconscious, their damage is already done, and actually, yeah, we get them out, we go to hospital. But actually, the group that I think we can make the biggest impact with are this group with occult injuries who might not be obviously catastrophically injured at that point in time, but leave it an hour and they will decompensate massively. And so we need to have them in hospital at that point of decompensation. So spotting that group, that is crucial. And that's kind of where we really earn our money. Not the easy, obvious ones, but these ones that are going to go off and need to come out sooner rather than later. So to help us understand that a bit more, we just need to think about which patients are likely to die and within which timeframes we can think about identifying them. And I'm sure we're all familiar with this trimodal distribution of death from 1983. So 3 peaks of death. There's people that die almost immediately. So they have got just immediate catastrophic injury. So, you know, it sounds a bit ridiculous, but decapitation, hemicorporectomy, incineration, really just catastrophic, massive head injury, great vessel tears, all that sort of thing. And that happens almost immediately. And we're not going to be on scene in the time frame to do anything about that. And even if we were, we probably couldn't do anything about most of these kind of injuries. The second peak is the peak I think we're really targeting. So these are the people who, if left untreated, will die within kind of the first half an hour to an hour, going on to a couple of hours. And these people, they arrest from things like catastrophic hemorrhage, occluded airway hypoxia, tension pneumothorax, hypovolemia, tamponade. You can see the list. But actually, all of those things on the list are things that we can treat and do something about. So as long as we get there and we think about these things early, so let's just say pelvic fracture, for example, the patient might not be hypotensive because they're compensating, they're young, they're fit, they're compensating. Perhaps where they are, the pelvis is splintered in the car, but when we move them, it's going to come out. So we need to look for the more subtle signs. And people talk about the hateful eight of venous collapse and pallor and clamminess and so on. So we need to look for the more subtle signs that these patients are unwell. And that will allow us to increase the speed of which we're getting them out. But more than that, by addressing this group and managing this period of hypoxia and hypotension and stuff well, we impact on this third peak as well. Now, this is multi-organ failure and sepsis and so on. But like I say, by impacting on that list early, we reduce the amount of impact on that third spike. So actually, by impacting on these things early, and impaction might just be recognizing it and getting them to definitive care quickly. That's a huge intervention. We are making a big impact. So I already said that. So the difficulty that we have, though, is that speed of extrication potentially causes more harm because it's moving the patient a bit more than a much more controlled extrication would do. So I would say that the starting position is probably that just about every patient we go to who is truly entrapped probably needs rapid extrication. So not that immediate extrication, but just sooner rather than later. So I would have that as my starting position, and I would step down to a fully controlled extrication once I'm happy that there's nothing untoward going on with that patient. But we need to balance that speed with the need to do no further harm. So you understand the paradox. If we wait for the patient to decompensate, then it's probably too late by that point. So that's why it's so important to read the wreckage, have a look at the mechanism, what's happened, try to understand what the injuries are likely to be suspicious and assume the worst. And that way, hopefully, we're not going to miss anything. This is always an interesting question, I think. Where should we be during the extrication? So if needed, obviously, we need to be in with the patient delivering care. But if not, I still see people that like to be inside the vehicle. It's somehow exciting. It's very dramatic and people like doing it. But actually, once you're in there, you are eyes in and you lose everything else around you. So if possible, you're much more effective to be stood back, overviewing that scene. You can watch the extrication, you can be looking at the monitors, you can be looking at everything else unfolding. So yeah, if you need to be in, and if you truly need to be in, if there's nobody else that can do that job, that's great. But like I say, if not, you're more effective, I think, to stand back and overview what's going on. So another question I often get asked is oh, amputation. Yeah, well, amputate and get them out, and that's brilliant. Actually, true amputation is very, very rare. So true amputation is cutting through bone and truly amputating a limb. What we see far more commonly is division of remaining tissue. So a person has got an incomplete amputation anyway. It's gone through the bone and there's a little bit of soft tissue holding it on. If we have to cut through that, that's fine, but that's not true amputation as such. Like I say, true amputation is we're cutting through bone to get that patient out. And it's very rare, but we're going to do that if the patient will die without us doing it. And it's as dramatic as that. So they've got a time-critical, life-threatening injury, which we can't manage with them in situ, and we cannot get them out in an acceptable time frame. At that point, we're going to be thinking about amputation. But it's quite a big deal, and it's not to be undertaken lightly. Okay, so it's there, it's in the box. We need to make sure it's something that we can offer, but it's not something we're jumping up and down to do. And I think the final question I wanted to just consider is, what about the agitated patient? Because we all come across those. Agitated patients can be very difficult to manage. They're going to make our extrication more difficult because they're non-compliant, and that's potentially going to complicate our scene dynamics. It makes people very frustrated, and that then just impacts negatively on everything we've got going on. In terms of the impact on the patient, they're agitated, they've got increased oxygen demand, increased myocardial demand, potentially putting up the ICP, potentially worsening bleeding. So actually, it's a lose-lose situation. An agitated patient is bad news, and we need to do something to manage that. Okay. So what we need to do to manage that is we need to consider the causes of agitation. So we need to think about the non-medical causes first. So these scenes are going to be very noisy. They're going to be potentially getting cold. Patients are going to need to be immobilized, and they may well not like that. They're going to be scared. They may be under the influence of alcohol, maybe under the influence of drugs. So actually, there's a lot of non-medical stuff which may be making somebody agitated. And we can intervene with some of those by explaining what's going on, by trying to be calm and compassionate with those people. But we also need to think about the medical causes. So pain is a big factor. If they're hypoxic or hypoglycemic, hypovolemic, perhaps they've got a brain injury, perhaps they're developing a tension pneumothorax or a tamponade, and there's many other things. But these are things we need to think about when we're trying to manage that agitated patient. When we try to treat the agitated patient, we need to treat the cause of the agitation. So basically, we go back to that list and work our way through it. The key thing to think about is the tension pneumothorax. I've seen that a few times now, where a patient's developing a tension, it's unrecognized, and they're becoming more and more and more agitated. So keep that at the forefront of your mind. We need to make sure that they're well analgesed, and we need to make sure that they're well oxygenated. Okay. Sometimes we're going to need to proceed to pharmacological options to treat their agitation, particularly if it's traumatic brain injury or something. And practitioners will use whatever is within their experience mostly, but ketamine or midazolam are common choices, and they've both got their pros and cons. Sometimes, particularly for a traumatic brain injury, we'll proceed to a pre-hospital anaesthetic, and that will allow us to reduce the agitation, obviously, but also increase sort of neuroprotective ventilatory strategies. The key thing is, as I mentioned earlier, with any drug, there are potential side effects, so we need to manage complications if and when they occur. So we need to be very mindful of that, and we don't just chuck in a whole bunch of midazolam to a patient who's trapped in a vehicle that we can't get to, for example. So final thoughts, just to pull some of that stuff together. Entrapped patients are more likely to be seriously injured and die than those that aren't. Extricating them is a complex procedure which can take a lot of time, and it's often centered around protecting the potential spinal injuries, but that can be to the detriment of actual time critical injuries. Each case must be considered on its own merits, and we should devise a plan between us and FHIR and the whole team to best meet the needs of that individual patient. We need to be prepared to step away from the confines of the traditional kind of stepwise ladder of extrication. So back to that summary, and before I finish, just acknowledge the Trauma Care Pre-Hospital Manual. I've used a few bits of that. The UKRO referred to that during this. Andy Thurgood, who's a friend and colleague in the West Midlands, he's given me some thoughts. And the Yorkshire Regional Faculty of Pre-Hospital Care Group, which is where most of those photos came from their CPD weekends, which we hold once a year. And he's great, so keep an eye out for that. Get yourself signed up. So I will hand back to Dawn for any questions.